All right, so I will introduce our final speaker, Dr. Veda. I'm not going to even try to pronounce and butcher your last name, but Dr. Veda, as we know him here, is the chief of our Neuromuscular division, a man of many talents and interests. He trained in India and again here in the US, including a neuromuscular fellowship, and came to us from the University of Mississippi, has been here with us at Dell since around 2020. And is running the muscular dystrophy clinic, works with our autonomic lab, and is going to talk to us today about diagnosing neuromuscular conditions in primary care. Dr. Veda.
Thanks for thank you for waiting, and so in the next 15-20 minutes, I'll try to cover some of the issues that are coming up and would be of interest to primary care physicians in relation to advances in neuromuscular medicine. I have no financial, relationship for this talk. So, just some introduction. So, the past decade, especially, has seen some major advances in treating neuromuscular disease, specifically genetically based neuromuscular conditions. So this becomes really important when we're addressing pediatric neuromuscular conditions. Previously, the two big problems that we encountered were Duchenne muscular dystrophy and spinal muscular atrophy, which really did not have any meaningful therapies, and now they have some really fantastic treatment for them. And it's also been recognized that we have gotten better with our ability to do multidisciplinary care. That means we have recognized that muscle disease doesn't affect the muscle alone, it's multiple organ systems. So when you get all of them together, the outcomes are better. And even disorders that do not have a disease-modifying therapy, we can change their outcome or make it better. This has been shown in multiple studies. The thing that has come out which makes logical sense, is that when you're going to treat something, you might as well treat it early rather than late. So you're more likely to get your best benefit if you do it in time. So this is actually, and I put it in, time is muscle strength. This is especially important in the context of some of our treatments that are disease for which we have treatments based on genetic therapy, SMA, and even Duchenne. The sooner we start disease modification, the better it is. And one of the challenges that we have is, in order to get to these patients, their first point of contact is usually with primary care providers. So we do not get to see them, and this is a universal challenge, not just to our community, and delays in diagnosis is frequent, and it can range from sometimes between 2 to 4 or even longer period of time that individuals with disease are recognized as having a neuromuscular condition. So my objectives were really to sort of highlight some gaps in the early diagnosis and their referral for disease-modifying therapy. We'll just show some of the clues that you might see in your practice that may lead you to consider neuromuscular disease in your office. And also just talk about impact of some of the common disease-modifying therapies. And also sort of talk to you about some resources that are available in the community. We'll just kind of quickly wrap it up with that. So if you go and look at the prevalence of chronic neurological disorders in childhood, neuromuscular disease is not the most frequent. This is a study from a nationwide cohort where they looked at a large number of kids, and then you find that neuromuscular conditions are about 1 in 3,000, whereas learning disabilities come in 1 in 15. So it's significantly less common, and but by the same token, the presence of treatment makes it more important that they be recognized. So the two most important ones that are of great interest these days is spinal muscular atrophy and Duchenne muscular dystrophy from our pediatric practice. Spinal muscular atrophy, as you all know, is a disorder which had a significant mortality, especially the type 1, which was the more common form, most children did not make it beyond the age of 2. And that has changed dramatically in the past 6 to 7 years. And this is based upon advances in knowing the genetic mechanisms and gene therapy. So I'm just going to sort of, discuss a little bit about the principles in the gene therapy, because that pretty much applies to the two big ones that we treat these days, both spinal muscular atrophy and Duchenne. So here's a picture which shows you the pathogenesis of the spinal muscular atrophy. And on your left-hand part of the panel, you can look on the top row. There is a red mark. This is exon 7 in the gene called SMN1. And this particular gene gets, in the mutation, you need this particular gene. It's important to form this protein called SMN1. The most common thing that happens is you see is the complete deletion of the whole gene, though sometimes you could have a point mutation. The most common form that leads to this disease is from that. So the absence of this gene, you do not make this very critical protein, which is needed in cells to process mRNAs of other types. So you do have a backup in all of us, otherwise you wouldn't really make it. And that's the SMN2. This is very similar to 1, except there is a splicing site at the 7 exon. So we all have different numbers of this particular gene SMN2. Some of us may have none of it if you have a functioning SMN1, but it could range from 1 through, you could have up to 5 or more copies. If you had a mutation of SMN1, then the number of SMN2 gene copies would determine the severity of your disease. So more the copy, less severe the disease. And so it makes sense. And the reason for that is that a small amount of the SMN2 gets transcribed into the whole protein. So if you had more of these, you're likely to have more of the protein coming through. So this becomes the basis for treatment for this condition. So we had the first one that came through was using a oligosense nucleotide, which is nothing but a skeleton which looks very much like the mRNA and it comes, so here's a picture of the diseased condition where you have a mutation, you end up in disrupted, you don't form the protein except a very small amount from SMN2. So now you use the oligonucleotide, which comes and sits right here and blocks the ability of that exon 7 to splice. So if you block this splicing at the exon 7, then you end up making a normal protein functionally, which pretty much means you repair. And this was the first treatment that came through in 2017, and it changed the landscape of how these kids' future was. Started stabilizing them, started improving. The problem with this particular approach was that you had to do this repetitively. you couldn't have it just as a one-time process. The same thing is also done for children with Duchenne muscular dystrophy. Certain types of mutations, we can use a oligosense nucleotide, which will then modify the splicing, and thereby you'll allow it to form a meaningful protein in those kids. The other thing that made a big difference was replacing the missing gene itself. So here, what you are doing is that you construct the gene, which is the SMN1, you make a promoter for it, and then you package it into a virus. Pretty much you are doing like a Trojan horse approach, and then you infect the child with the virus. So this is the adeno-associated virus, which then has a predilection to enter the nervous system. And in the cell, it will release the genetic information, but this particular gene does not integrate within your nuclear DNA. So that stays separate, and this becomes an independent a unit that can make protein by itself. Why is this important? Because if you integrate the gene into your native DNA, there is a possibility of causing errors, which can then mean lack of certain proteins and even increase your risk for oncogenesis and that sort of problems. So this one is completely and entirely outside of the nuclear genome. And the same principle is available for Duchenne dystrophy as well. We now use it for children between the ages of 4 and 6. And this is, the trade name for that is Elevidys. The trade name for SMA is Zolgensma. Both of these things are now, we use them as for children who are appropriate for the particular indication. So this brings up the next question, how can we quickly and in timely fashion identify, because in both these situations, time is of essence, especially in the SMA, you want to be as quick as you can, and in the Duchenne, the window of time where you can treat them is short and critical, and you don't want to miss the opportunity. So this is a publication that was in Wisconsin Medical Journal. It's sort of small, but it sort of looked at what is the pediatrician's exposure to neuromuscular disease. So they were looking at this medical center, which had a fairly robust neuromuscular service for kids with about 811 patients in their practice. And the local pediatricians, they were polled. There were a total of 144 in the surrounding area. So when they looked at them, about 74 of them had patients with neuromuscular disease whom they had seen at some point. And then what's more important is equally about 70, which is almost 50% of the pediatricians, did not see a neuromuscular disease patient, even though they were all in the same sort of area of practice, which really means they really truly did not have an ability to recognize both how to identify quickly and also to identify their needs in terms of the primary care. So the median number was 2.5. So that is the number of neuromuscular disease patients a pediatrician had in that practice or in that area. And the highest was about 7. So there's still more work to be done. We need to sort of improve the knowledge base and for our primary care providers. So one of the things that has come out as a saving grace, at least for the SMA patients, is the newborn screening. This has changed the scene. As a result of newborn screening, we don't miss the diagnosis almost in all of the states in the United States at this time. I mean, every state does provide newborn screening for SMA, and 8 other countries in the world does it. But there's still a significant amount of children in the other parts of the world who do not get detected. So time is a sense, especially that we have learned that if you delay treatment, the outcome, even with these effective medications, you don't get a good response in terms of their prognosis for achieving milestones and development. So you also need to remember that about 5% of SMA children will be missed by the currently available newborn screening methods. So there's no security, so one cannot say that just because, the child was born after the newborn screening started, so they would be screened, that's not the fact. So you could still miss, and you still have to consider if the picture is suspicious, that can happen. And I'm going to just show you, this is a child with Duchenne muscular dystrophy that we currently had. And to point out how we have, the challenge of diagnosis and time is more critical in this situation. So this is we saw him in November of 23. He's a 4-year-old. This was when he first started. He was having episodes of calf pain and thigh pain. He was initially seen by primary care providers and given the diagnosis of growing pains. Pain persisted, and then he was sent to a physical therapist. And he continued with the physical therapist for 6 months and didn't see much improvement, but sort of was still continuing to have issues. Then he was noted to have, in fact, a worsening of his condition with toe walking and change in his gait and balance. And that's when he was referred to his primary care pediatrician, who did a CMP and a CBC. He was noted to have increased AST and ALT. So they initially thought this was related to his liver disease, and he went to see a gastroenterologist, and then subsequently had a CK, which was, again, 12,000. He had a liver biopsy, which, of course, was normal, and then had a muscle biopsy, which I think was not required. And that showed that there was an abnormality in the dystrophin staining, thereby making a diagnosis of Duchenne dystrophy. The time interval between his first symptom and the time that he got to see us was about 1 year and 10 months. And when he was seen in our clinic, he hadn't had his genetic studies as yet, even though he had a muscle biopsy. So he had one of our fairly rapid testing, and that established that he had a genetic makeup that could be treated with gene therapy. And he got his treatment, which was Elevidys, at 5 years and 11 months and 3 weeks. So all that was left was we had a 2-week interval before he would reach the age cutoff to receive gene therapy. So we were almost at the brink. So if he were delayed by, say, a couple more weeks, he could have ended up, not receiving the gene therapy. The child has gotten it, and he's now 6 months into it. So what this, presentation really points out is the importance that these children need to be, recognized and sent, especially in some of these, and the number of muscle disease that are going to be approachable by this is going to only increase as we go forwards from now. So this is some issues with delays in diagnosing Duchenne. At present, we do not have a newborn screening. They attempted in a few states in small studies, and it's still not kind of gotten on in a big way. There are more technical issues because of the variability of the gene makeup that can cause Duchenne. So the last 30 years, what we have recognized is that the time it takes to make a diagnosis has not changed. So generally, we don't recognize this diagnosis until they're about 4.5 years to almost 5 years before the children get identified as having possibly Duchenne. And I just point out that the disease-modifying therapy, again, is best if it is started early, and also there is a time importance of timing when to start this. The antisense oligonucleotide therapy, we can start it as early as 3 years of age. You may get a better outcome. Steroids and its analogs that we have now can start at 3. Microdystrophin gene therapy has to be done between ages 4 and 6. It might expand, but we'll have to wait to see. So time is essential, and prompt diagnosis is important. So this is a publication from Newcastle, which is a large neuromuscular medicine group. So they looked at 35 of their patients with Duchenne. First symptoms occurred between ages of 8 months and 72 months. And then the first contact with the healthcare took about 10 to 90 months. The creatine kinase, which is the blood test that often leads to this diagnosis, took about 14 to 91 months. And then a diagnosis interval between 16 to 91. I need to point out that the younger kids who were identified where often the clue was that their parents indicated that they had a sibling who had a diagnosis, which then leads to early. Otherwise, the first de novo kid who starts in a family often gets delayed significantly, and it's a big issue. So overall, between parental concern to the diagnosis could range between 4 months and 50 months. So parents can recognize something that's not quite right, but so this particular change or this particular timing issue is not, unique to them, but it's all over. So this is just a table to give you about for disease-modifying therapy for Duchenne and when we can start. And what you could see is that they all have importance that we don't want to wait. You could even start them before age 5. And then if you look at on the SMA group, you also have a time, like Zolgensma, the gene therapy cannot be given after age 2. The gene therapy for microdystrophin cannot be given after age 6. So what do parents generally come up with, these common neuromuscular conditions? So when you look at, this is a paper where they were asking, and these are some of the common complaints, and they were kind of sometimes, overlooked or dismissed as being, growing pains. So for instance, in Duchenne, a child is walking slowly and falling more often. And often what happens is the child gets referred to physical therapy as a means that, it's a minor issue. Not reaching milestones like his sibling or like other kids of his age. He seems to be weaker than other, babies, and he's not saying words. This is much earlier. So on SMA, it's like cannot hold head up and cannot do tummy time. Slow in crawling and cannot put weight on their legs. Has hand tremors. That's a very typical thing that is seen in SMA because of loss of motor neurons and falling a lot and walking funny. Now, this is an important developmental milestones table, which is quite simple, and this has been validated in multiple populations across the world. So this has several hundred thousand kids who were evaluated. And this is very helpful because it has these important motor milestones that, for instance, If a child does not walk at 18 months of age, that's abnormal. If the child cannot stand by about 17 and a half months, that's clearly, something is not right in the motor realm of developmental abilities. And so in the most common phenotype you would encounter in your practice is the floppy infant. And of course, floppy in an infant could happen from disease of muscle, nerve, neuromuscular junction, and brain and central nervous system. So the important clue in this sort of setting would be that if you see an absence of reflexes, it should immediately ring a red flag that this could potentially be a neuromuscular problem rather than a central. Though it can happen that you could see this also with central issue, but more often this indicates a peripheral etiology. So here, sometimes you may see abnormal facial appearance. This is one of my patients. They just thought he had, he had droopy eyes, but failed to recognize, but this was a myasthenia in a child. So they thought he was just lazy-eyed, and this went on for months. Quite often, the most important part of an exam is, sometimes we overlook, is looking at their feet. And this especially can be in small children, and especially teenagers and adolescents. You don't take their shoes or footwear or socks off, and then you miss a lot of findings. So here you have, club feet, and that tells you, there has been some problems either with the motor system peripherally, or it's central. So it could be upper motor neuron, or it could be neuropathies or muscle disease. So evaluating this is very important. This is more important, or you may see kids who have high arches, and that's a clue towards, inherited neuropathies. And we are soon going to be possibly have treatments for this. And similarly, high arches can be part of a muscle disease. And high arches, when it's asymmetric, it could give you a clue that there may be a problem from the spinal cord related problem. And the other one is, children who have flat feet. So that again indicates the same sort of. But many times I've seen children are reluctant to take their shoes off and socks off, and missing that would, make you miss a lot of very important clinical clues. The common blood test that's done in the office is creatine kinase. As you know, this is an enzyme that helps to provide immediate energy for muscle contraction. It is released from the muscle when it's leaky or injured. So normal range, we have between 40 and 200. Now, mild elevation can be seen with congenital muscle disease, muscular dystrophies, and myositis. Moderate, in myositis and muscular dystrophies, and severe in rhabdomyolysis. This is quite easy to find, and most often, for some reason, this is not commonly ordered in practice. This should especially be ordered if you see elevated liver function abnormality, AST, ALT, without any other abnormalities in the liver function panel. Say if the albumin is normal, the bilirubin is normal, and one of them which is important, which is unfortunately not done, is GGT. If GGT is normal and AST, ALT are normal, there's a high likelihood that you're dealing with muscle disease and not really a liver problem, such as the patient that we kind of talked about. Now, there are multiple resources that we have currently. We have Muscular Dystrophy Association, which along with giving clinical services, also has resources that will talk about common muscle disease and also questions related to their care and immunization and primary care issues, even anesthesia related. There's Parent Project for Muscular Dystrophy, Cure SMA, Cure CMD, Cure Duchenne, and CMT. So there are all these which provide very useful information for about diet, exercise, medications, and how to deal with emergencies. And so, and to conclude, so the last decade has come up with some important major development in disease-modifying treatments. We have the two ones that are currently clinically available, and we know very clearly that time is essence, especially for gene therapy, for it to be effective. So early recognition for neuromuscular disease is important. And of course, the first point of contact for our patients is through primary care. And some of these clues need to be recognized. And then there are also, more resources if you had questions about how to care for them along with. And we have a muscular dystrophy clinic, we have neuromuscular clinics, and we have a coordinator. And once you reach our system, we are available to answer questions, and we try to bring them as quickly as we can to be seen by me or my colleague. And with that, I will stop and take some questions. Okay, yes, sir. Yes, sir.
So we have gene therapy for SMA and somewhat less effective gene therapy for Duchenne. What do you think the next big series of gene therapy is going to be?
I think the next one would be Charcot-Marie-Tooth. And then sooner than later, I think we're going to go into specifically what we can call as, like you would have a designer kind of gene therapy, like you have the AAV virus, and then you try to find out what's missing, and then you can sort of order, like, I need such and such thing, and it'll be available.
So order like from Amazon, you mean?
Could be. I mean, they already are doing it, like in a CAR therapy, like the T cell. So you would have the same sort of thing that you identify, what is it, and then you prove that, and then you can sort of, get it. Yes, sir.
How likely the presence of deep tendon reflexes excludes the possibility of type 2 or type 3 SMA? We understand that type 1, we generally have loss of reflexes when they are born.
Right.
But like type 2 and type 3, if there is a good reflexes, can you just say this is unlikely so, or?
Type 2, yeah, you lose them. And type 3, you may have it, but none of them will have brisk reflexes. I mean, it'll be, in my experience, even type 3, you have to work, pretty hard to find it. So our approach is, at least my clinical approach is, whenever I see babies who are hypotonic and they're weak, I do the genetic testing because it's easy, it's foolproof. I will not miss the diagnosis. I don't want to miss it, even if it is, say, SMA4. You could make a difference. Yes.
Are there any tips or tricks for physical exam maneuvers that you could offer to try and differentiate hypotonia from weakness in small babies?
It's very, very challenging in the small babies to tell, are they really weak or are they hypotonic? But many times they both run together. So my important thing is presence of good tendon reflexes will favor more central hypotonia. Number 2 is presence of abnormal or persistence of neonatal reflexes. Like you mentioned, persistence of grasp response in their feet, persistence of asymmetric tonic neck responses, those would favor more towards that being a sentinel lesion.
I'm sorry if you mentioned this before and I missed it, but do you recommend going with a neuromuscular panel for genetic testing first, or like doing exon sequencing, or because there are cases where exon sequencing could miss a mutation or something?
Are you talking in reference to SMA or any muscle disease?
Just in general, if we're
Okay.
looking for a muscle issue.
Well, the thing about, you have to be careful about ordering genetic tests that you will see variant of uncertain significance. So you need to be sort of be ready to deal with that. So in my practice, I would order the neuromuscular panel, and of course I do counsel them prior to the panel that we can miss the diagnosis because it's only good, its sensitivity about 40 to 50%. On top of that, we also counsel them that there would be variants of uncertain significance. And we also tell them that if that appears, it may lead to further testing, uncertainty, or even observation. So I would think, that in the primary care practice, it would be better that they would send it further because, rather than doing the testing and increasing the anxiety, saying that, I had this mutation, saying that you possibly have a muscle disease, so you come up to see a neurologist, neuromuscular specialist, so that way we'll have a continuity and. Okay, thank you. Thank you.